Good evening, everyone, and thanks for joining us from wherever you are this evening for the 11th in our COVID update series. And we hope that we'll be able to address a lot of the questions that have been provided for us this evening. So my name's Catherine Turner. I'm one of the exec managers at the Primary Health Network, and I'd like to begin, as always, by acknowledging that we're meeting on Aboriginal land and acknowledge the traditional custodians of the land we live and work on as the first people of our country. And I acknowledge elders past and present. And I also want to recognise that each of you are currently working under some very different conditions, and thank everyone for the care of the community. So we're slightly different format tonight. So tonight we're using GoToMeeting. We will have some very short presentations from only a couple of presenters, and then we're going to move to a panel discussion where hopefully we'll be able to have some more interaction with all of you. There are some questions on the chat, but we'd prefer that all questions went via the Slido link, which was sent to you in the invitation, and you can see it there on the screen. The hashtag for tonight is PHN11, and we'd also like to remind you to complete the evaluation at the end, making sure that you let us know what other topics of interest to you. So tonight I'm going to give a brief update on what the Primary Health Network has been working on currently in the COVID situation. We'll have an epidemiology update from Kat Taylor and Tony Merritt from HNE's Public Health Unit. Then we'll have a panel discussion which will tonight include John Ferguson, local infectious diseases physician, and GP representatives tonight will be Tony and Kim Isaac from Katara Family Practice. So we've given our Central Coast colleagues the evening off tonight, but that's not to say that we're just trying to share around some of the load with these very much more frequent updates as we're providing them. So hopefully the information that you're looking for will be here in the presentations. So without ado, some of the key things that have really sprung up, particularly over the last week, we were all interested to see a release from the Clinical Excellence Commission last Friday on an escalation of the alert status from New South Wales Health. So whilst the status applies to New South Wales health workers and their patients, this is an extract out of an update which you'll see on Health Pathways, which has really enabled us to use the New South Wales Health update and corresponding advice from the RACGP, which which obviously isn't a mandate, but certainly a very strong recommendation that in light of the increased community transmission, there is a need to increase infection control strategies. Currently, advice is that New South Wales health workers particularly and others should wear a surgical mask if they are within 1.5 metres of patients. Patients are also required to wear masks where possible. This has been supported by the RACGP, and we would advise, and as always, that mask wearing isn't supplements, but is not a substitute for all of the other precautions that we've been taking, which I'm sure we'll hear more about tonight in the next presentations. So other things that we've been focusing on, so of course with the increase in the requirements around masks, we had over 200 requests for masks come through on our portal over the weekend, which we had expected. So the primary care improvement team are out and about delivering those. So they've certainly undertaken a lot of those today, and tomorrow there'll be more deliveries. There are supplies heading from Erina to Tamworth to make sure that we get all of the practices covered with the requirements that they currently have. There is adequate supply of surgical masks and N95 masks currently sitting in the PHN, a combination of masks from the stockpile and some donated masks. So we are moving to address those as quickly as we can. We've also looked, we've also been collating in on our website an alternate list of suppliers for other items. So we know that there have been some disruptions to the supply chain for gloves, gowns. We know there's an increasing request for face shields. We have some of those things. We have, face shields and masks on available for distribution, but we've also collected some information about other suppliers where there might be some. We've had a lot of contact from people, particularly residential aged care and others, who are saying they can't access things through their usual supply chain. So we're trying to do our best to make sure that we keep an up-to-date list so that you can follow down other elements as needed. We've also made some moves to purchase other equipment to keep in stock so that if there is an outbreak and any disruption, that we'll have some equipment that can be made very rapidly available. We've all been watching with heavy hearts the current situation in Victoria around residential aged care, and as you know, we've been very focused working with our local health district teams and New South Wales Ambulance. We've had GP clinical advice from Jennifer Briggs and others on trying our best to prepare the local residential aged care facilities. So recently we've been back in touch with them again as late as last Thursday and Friday, reinforcing preparedness, making sure that their plans are up to date, seeing what other information or supplies they might be requiring, reminding them about the training that's been made available, and reminding them of the supports that are available for them. Over the weekend, as you know, in response to the positive cases in the Port Stephens region, there was quite an increased requirement for testing or demand for testing. So to help that, we were able to contact some of the local practices who agreed to provide some additional hours over the weekend to enable people to get some referrals so they could take those to private pathology. This was only came up late Friday, and we're really pleased that some of the practices were able to take that offer up, and we have made some grants available to cover the costs for GPs who've been able to do that for us. We think that's a good model. We'll soon find out and see if that was effective over the weekend, and that might be something that we would do again in response to local outbreaks. So we're also refining our emergency response and support. It's been a good time to make sure that we internally have all of the processes required that we need, and we've an emergency operations centre email which we're monitoring obviously and sharing. We've got an incident control process established, and we'll be sharing that email for anybody who might need it. So the last thing I just want to remind you about is the capacity tracker. Again, this is a supplementary tool that we've been using for residential aged care, general practice and AMSs to provide some data to help us be better able to provide some of that system coordination, which we really believe is required. The link is there, and we'd be very keen to talk to people about that and potential uses for it. Where are we up to with the capacity tracker? We've got 51% of the general practices registered and providing information, 68% of aged care facilities registered and provided information. We've had a number of alerts come through in the last week just about impact on workforce and also PPE requirements. So you can see, sorry, from that slide, it's a bit blurry next to you. That's the sort of form that we ask people to complete, and to particularly let us know if they have issues with access to PPE and whether they're being impacted by any cases or staff being in quarantine. Have to say, pleased that that's working. We've been able to address each of the alerts as they've come through on the same working day. And it just gives us another opportunity to improve coordination of impact during any localised outbreaks. Happy to take any questions or comments about that as we move on. They're probably the key things from the Primary Health Network. So we are busily talking to lots of people and getting information, advice, and we're still continuing with the telehealth work and some of the other pieces of work that you've identified are priorities for us coming out of the lockdown some time ago. Probably not a lockdown, it's probably not the right term. So with that, I'm going to hand over to Kat and Tony to give us their updates, and I'll be here with you if there's any questions at the end. Thanks.
Thank you very much, Catherine. I'm hoping that you can see my screen. Sorry, I'll just do a quick little bit of adjustment here. So for those of you that don't know me, my name is Kat Taylor. I'm one of the public health physicians at Hunter New England Population Health Unit, and I'm joined by an illustrious panel tonight, including my colleague Tony Merritt, also at the PHU, also Dr. John Ferguson, infectious diseases and infection prevention and control specialist at John Hunter, and also the lovely Kim and Tony Isaacs from Katara Family Practice. So we won't spend too long on this formal presentation because we do want to give ample time to all of your questions. So what a difference a month makes. I think, a month ago we were talking about dancing with this virus, but I think, the tune has changed very much now to an approach of seek and destroy. We, as Catherine said, have all been watching the situation in Victoria unfold with a sense of foreboding. And I thought that I'd just give a quick little overview of the epidemiology locally, and then also focus in a little on the recent cases that we've seen, just to give a flavour of the current context that we're dealing with in the Hunter New England region. So one of the questions that we often get asked is New South Wales just 2 weeks behind Victoria? And I think one of the prompts for that question has been related to essentially seeing that Victoria first began to experience an increase in cases. They saw more than 10 cases back on the 15th of June. And from there, it's really taken off. And then New South Wales 2 weeks later first registered cases above 10. So I think there were 15 cases in New South Wales on the 1st of July. But I just wanted to present this graphic, which shows quite a stark contrast, as you can see, between New South Wales and Victorian situation, the Victorian line in red, just to illustrate that really Victoria is in a very different position from New South Wales currently, in the sense that their case numbers have been doubling really every week since they first had that increase noted in the middle of June. New South Wales has taken quite aggressive containment measures. As most of you would be aware, the borders to Victoria closed on the 8th of July. So it's been some time now since those restrictions were imposed, and then there's been quite aggressive contact tracing and case finding that's been occurring in New South Wales in response to the incursions that have been experienced. And you'd all be familiar with some of the headlines that have been reported, first with the Crossroads pub and then subsequently with the Tie Rock cluster in southern Sydney. And we can see that there's been a huge amount of kind of cleanup effort that's gone in around those clusters, and it's still ongoing. We're up to tertiary and quaternary transmission now from those cases. But just to give you a flavour of the current New South Wales position, over the last 24 hours, we had 17 new cases reported, of which 8 were overseas acquired. So these are people that are in quarantine hotels. There were 7 that were locally acquired but known contacts of either a confirmed case or a cluster. So there was a known source there. And there were also 2 of unknown source. And obviously those unknown source cases do give us cause for concern, in the sense of worrying about potential community transmission in those areas, or potential missed community transmission links. And so there is a phenomenal effort going in with a surged response in both New South Wales and Hunter New England Health in really just trying to track down all of the people that have been in contact with identified cases, because that really is our best defence against the virus. And you can see from this graphic that New South Wales has actually been doing quite well at that. So not just getting cases into isolation so they can no longer infect others, but getting that next ring out into isolation of contacts so that they can, so that they are already in isolation by the time they develop symptoms and become infectious. Closer to home, you'd all be fairly familiar with the Hunter New England epidemic curve. You would note here the familiar first wave, so-called, back in sort of March and April of this year. A huge spike associated with the Ruby Princess return, and then a precipitous decline associated with the closure of international borders and a range of restrictions that were brought in, and as well as the restrictions on movement and gathering. And I'd like to draw your attention now to the grey, I'm not sure if you can see my cursor, but the grey boxes here, which reflect essentially what we were talking about, those locally acquired cases with an unknown source. And just highlighting that the last such case remains back on the 15th of April. We have had no unknown source cases in Hunter New England since then. Okay, so you can see at the edge of this epidemic curve that we are starting to get a few cases here. And the breakdown of those is we have had overseas acquired, but most recently we have also had a couple of locally acquired that were associated with an imported overseas case, and then also several that have been associated with a Sydney imported case. And I thought that we'd take the opportunity tonight just to give you a little bit more depth about those recent cases. Obviously, in the current climate, they've been the source of a lot of interest and redoubled efforts to contain the virus. So I might hand over to Tony now. I've still got my slides up, Tony, but I think you should be able to speak over the top.
Oh, let's give that a try. Great. Thanks. Nice to join everyone. Thanks for that, Kat. Look, a little bit of detail here, but there's just a few key messages. Each one of these horizontal lines represents a person's journey through COVID or not COVID. And the top two are a couple who returned from the United Kingdom, and they arrived in Australia back on the 21st of June, went into hotel quarantine in Sydney. And the I guess the legend here, the green squares are tests that were negative for COVID, the red squares tests for COVID that were positive. And they both were tested on day 10 and released at the end of quarantine, came up to our neck of the woods and had a big family gathering on the 4th of July. And so they'd served out their quarantine. The quarantine period's actually been recalculated slightly since then. Under current rules, they would have stayed in the hotel quarantine an extra day or so, which might have nipped this in the bud. But one of the points here is that they became cases, or one of them became a case after at least a 14-day incubation period. And it just underlines why we've got the 14 days. While the median incubation's around that 5 or 6 days, some are going to run right to the end of that period of time. The next takeaway is that on that 4th, he completely legitimately released from quarantine, had the family gathering, and he was well. There were no symptoms. He didn't become unwell or symptomatic, and at that time they were mild symptoms until the next day when he was tested and was positive into isolation and has done well. But on the day that he was asymptomatic, he managed to infect the two people represented by the horizontal bars at the bottom. So again, I guess the second big takeaway just reinforces a point we know well now, that people can be infectious before symptom onset, makes it challenging dealing with COVID in so many ways. But he successfully infected these two people down the bottom. The grey horizontal line is his partner, who remains stubbornly COVID negative, which is terrific throughout. And I think that's intriguing. It's just possible that she, in fact, had COVID earlier in Europe, and we're waiting for her serology with great interest. But on to the local family members at the bottom, these two, again, a couple of takeaways. Their incubation period, a little bit longer than usual. They both developed symptoms 8 days after exposure. This is the only reasonable exposure for those two, so we know that's where they became infected. Importantly, you can see the green squares there on, what's that, the 7th of July. They were tested into this period of isolation, and we know they were incubating the virus at this stage, and their COVID tests, the PCR tests, were negative on about day 3 of their incubation. And it's just a key reminder that early testing in people is no predictor of what's going to happen later on. If negative, no reassurance about what might happen down the track. So important for people who are turning up asking for a PCR, a swab test today to make sure they're not going to become sick, having just been potentially exposed to someone. Kat, we'll just go back fractionally. And then just the final point was this couple both became symptomatic on the 12th. One was test positive, and it's the green square at the bottom which I think exercises this most of all. The very bottom horizontal line, second day of symptoms, COVID PCR test was negative. She remained in isolation, was positive 2 days later. And that's perhaps the theme of the next slide, Kat. Thanks for advancing if you're in control there. And I think some of you will have seen this graphic before, but it goes to this kind of challenging issue of false negative PCRs for COVID. Just focus on that top graphic. And these are all people, it's a summation of a series of studies, but these are all people who are infected with COVID, and it's a representation of the likelihood of a PCR on any one day post-infection actually being positive. And you start on day 0 after exposure and infection, but before symptoms, of almost a complete probability of 1 that the PCR would be negative. And at the very best it gets is around 20% negative. So even when people have the highest viral load here around day 2 or 3 of symptoms, still a 20% chance of a false negative PCR test. And again, so it's sobering and plays into our practice. There's been lots of questions from you, I appreciate, about how to respond to negative PCR tests in the face of significant clinical suspicion. So Kat, I think that takes us on to the next slide. So key takeaways, I think I've touched on the first 3 really. In terms of, we can discuss this further, but in terms of responding to a negative PCR in the context where you really highly suspect COVID, and it might be a family member of a confirmed case, for example, or a high level exposure, then we all need to use our appropriate level of clinical suspicion and acumen. And if COVID's highly suspected, keep those people in isolation and repeat the test. There's no magic formula in terms of how many days to wait. You could see in the person who I mentioned last in that cluster of 4, we repeated her test 2 days after her negative. We were quite sure she was going to become a case. And Kat, I think that's that slide. What's next? I think it might be back to you.
Thanks very much, Tony. So that was a great overview of that recent cluster. More recently, you probably would be aware of the cluster in Port Stephens. And I just thought, unfortunately, don't have as beautiful a graphic as Tony, but just thought we'd give a little overview of the sequence of events there. So most of you might be aware that the index case for this introduction was Sydney acquired, so someone that had been to the Thai Rock restaurant. They subsequently visited Port Stephens as part of their work. They had a work appointment with Port Stephens family on the 13th of July, and notably this was 1 day before their symptom onset on the 14th, so similar to Tony's previous case. So subsequently, unfortunately, somebody in that household that was there at that visit, it was just a brief visit, 20 minutes, apparently no PPE was used, had the onset of symptoms on the 16th of July. So this was shortness of breath, cough, fairly typical symptoms. However, given that this person, hadn't really travelled anywhere, hadn't been outside of Port Stephens, hadn't had any known contact with people from overseas or Victoria, they actually sort of didn't think to get tested until later in the week. So their positive test result was on the 20th of the 7th. And similarly, this initial case 1 had met with some of their extended family members the day before, the 15th of the 7th, day before their onset. And those family members subsequently went on to develop symptoms and test positive. I won't dwell on the details of the case, but just to say that these 3 people, between them, so cases 2, 3, and 4, similarly, there was a lowish index of suspicion prior to finding out about case 1's diagnosis. So before they were notified that they were close contacts, and put into isolation, they had attended a number of very complex settings, and you would be aware of the media around these settings. So Woolworths, Salamander Bay, Tomaree Primary School, a childcare centre in Anna Bay, and also a junior AFL team. And so this was the subject of a lot of activity last Thursday, following up all of the people and assessing, people for their level of contact with those cases. And in all, we're currently have 155 active close contacts that Hunter New England Health is following up. And so just an indication that just from that single introduction, with some slight delay in diagnosis and I guess a low sort of index of suspicion in those people, leading to maybe a delay to getting tested and not going into isolation, we wound up with 155 close contacts from those recent cases. And so if you imagine, if we were in a Victorian situation where we didn't have 4 new cases, we actually had 500 new cases a day, that, tracing all of those contacts would really just be an impossibility. So I think the key take homes from this vignette is really that, there is that potential now for large numbers of close contacts under the context of eased restrictions. So obviously, life is returning somewhat to normal, in the sense of, sports resuming and community activities resuming and people socialising more. And so this always does give the potential, if and when COVID-19 gets into the community undetected, for it to spread quite rapidly. Noting that we have not yet seen any evidence of forward transmission. So this initial transmission that we're talking about occurred in sort of household contact type settings. So we shall wait and see. I think the other key things that are brought up by this case are really who to test. And I know there's been a lot of confusion recently, the subject of a lot of calls to the public health unit regarding, the messages around testing. So just to confirm that there are 2 different approaches currently in New South Wales. There's an outbreak investigation approach. So this is what would be applied to, for example, the Thai Rock restaurant or the Kashula Crossroads Hotel, where multiple cases have been linked to that venue or that site that are not linked in any other way to each other. So that becomes the subject of an active outbreak investigation. And this is where we would be recommending widespread quarantining, so self-isolation for 14 days of people that had been there at those times, and also testing irrespective of symptoms. So that's a New South Wales approach, which goes beyond the usual public health approach, and is considered consistent with an outbreak investigation. The other list of places that will be mentioned, so you may be familiar with the New South Wales Health alerts page, COVID-19 alerts page, and this will list the isolate and test locations, but then there's also monitor for symptoms and get tested if any symptoms develop. And this is what we refer to as places of interest. So many of the places listed in the Port Stephens cluster, so Salamander Bay shops, for example, were simply places of interest. So people that have been to those shops do not need to isolate themselves. They do not need to be tested if they have no symptoms, but certainly we are promoting a heightened awareness for symptoms in the Port Stephens community, and for testing at the slightest of symptoms. In terms of asymptomatic testing, I won't dwell on that, but there's really a limited role for it. Public health does consider it, as I said, under settings of outbreak investigations, and also in people in whom the diagnosis is strongly expected. As Tony mentioned, people that are very, very close contacts of known cases, or are recently returned international travellers, they are all subjected to testing towards the end of their quarantine period, irrespective of symptoms. So just moving on to who to isolate, there are also a lot of community questions coming through about what are my isolation requirements. So anybody who was identified as a close contact, should I say, of any known cases or clusters is contacted by the public health unit and told to go into 14 days of quarantine, self-isolation. And so these people should know that they are meant to be in isolation. They will have had a conversation with public health. Then the second category of people is anybody who has symptoms, no matter how mild. We've been promoting for some time now that anybody with even the slightest of symptoms should get COVID-19 testing, particularly, you know, as we get into the thick of winter, everybody's huddling indoors, and there are a few respiratory viruses, picornavirus, for example, circulating. We are recommending that anyone that develops new symptoms should be tested. And for those that are known contacts of cases who are in isolation and develop symptoms, they must remain isolated for that full 14 days after their last exposure to COVID-19, irrespective of negative test results. For those that do not have any known close contact with cases or clusters, the isolation is advised until they've received their negative COVID-19 result and their symptoms resolve. So as I mentioned before, a lot of respiratory viruses circulating, and obviously the less those are transmitted, the less people will need to be unnecessarily tested. So even if it's not coronavirus, it may still be some sort of a contagious respiratory infection. And we're trying to minimise the circulation of those at this point in time. I've just put a little asterisk there about contacts. Interestingly, if you're a close contact who becomes a case, you may actually need to isolate for less time than a contact. And the principles behind that are that the 14-day isolation period is based around what we know as the longest known incubation period. So it's really giving the full period of time for the virus to declare itself. Whereas if somebody is confirmed as a case, then the previous recommendations will apply around being at least 10 days since the onset of symptoms, and also free of symptoms for at least 72 hours. But I won't dwell on that. The key messages are that anybody who has any symptoms should be tested. Those that are known contacts of COVID-19 still need to serve out the full 14-day period of their quarantine. And those that don't have any known COVID-19 exposure only need to isolate until they get a negative result and until they have recovered from their symptoms. Right, well, I will pause there, and I think now we're requesting the other panelists to turn on their webcams. And we might flick on to the Slido questions. Okay. So it's very strange not having any audience feedback, but I'm going to launch straight into it. So I will go from the top because I think in Slido we've got some upvoted questions, and we'll see how far we get through in our remaining half hour, and anything we can't answer tonight we will endeavour to take on notice and distribute some written responses to. So kicking off, I think this one might be appropriately directed to you, John Ferguson. So the question is, should we be wearing masks in primary care even when there has been no infections for some time?
Right, well this probably is a question for Tony. We were taken a bit by surprise on Friday, the escalation to amber status, and certainly across clinical care in the hospital we are wearing masks for any patient interaction within 1.5 metres. And that's mainly being done as a source control measure. My understanding is that from the most part, but also protective. I think general practice is included in the same category, so that contact with patient within 1.5 metres involves wearing a mask. Now, you can use the same mask through a whole session of care provided you don't take it off and it doesn't get moist. So we can conserve masks to some extent, but Kim and Tony might wish to comment.
Yeah, we took notice of that Amber Alert, and we are now wearing masks for all our patient interactions. And if the patients have a mask of their own and they feel comfortable wearing it, then we encourage them to wear that as well. Interestingly, our staff were also very keen for some direction based on the escalation of cases locally. So I think they were somewhat happy with the state government's escalation to an Amber Alert, interestingly. But we also still do our triaging of, respiratory patients, and are still trying to be very mindful of how we manage that group of people, that group of patients. So, and also the other restriction, or the other thing that we're keeping in mind, is how much face-to-face time we're actually spending with the patient, and trying to keep most of our appointments to shorter, less than 15-minute appointments if we can. Got anything to say?
No. Thanks. Catherine, did you want to speak to the question about mask recommendation in primary care at all? I think you did touch on this in your earlier comments.
Not really, except to say that there was, I guess, some enthusiasm for a directive to come out to say, you must do this, or but that's unlikely to happen. And so we're really just encouraging people to use the judgment to interpret both what the RACGP have provided and to follow the direction that New South Wales Health have implemented for their own staff. I mean, I think the question about locations where there haven't been any cases is probably one, because we have had some locations across the whole region where there's been no positive cases at all, I believe. So I would be curious to see. I mean, I think given everything we've heard about asymptomatic cases, can guess what your advice would be, but I just think it'd be good to explore that a wee bit.
Tony Merritt, did you want to make a comment?
Oh, look, I think when it's come up in the past, very reasonably, the discussion's always been around reflecting the local epidemiology, and if there was ongoing community transmission, then I think it's very straightforward answer, in terms of masks being appropriate for people providing clinical care. Now, this is a kind of troubling week, and we don't know where we'll be in another week's time. It obviously looked quite dynamic last week. We've got a group of people still symptomatic waiting for tests overnight, so it could be a very different picture. It could be a picture of ongoing transmission by the end of the week, or next week we may really have been over this hump and just had a small cluster. So I think, as a general principle, it really makes sense to reflect what's happening locally. And I think that is helpful. And as Catherine has indicated, in terms of guidance coming out of RACGP, there's that recommendation for GPs to consider. I think that obviously is very pertinent in the context that's provided broadly rather than focused on local epi.
Thanks, Tony. And I think, as kind of illustrated by our earlier slides, we have in Hunter, New England, been able to fully trace the kind of chains of transmission of the most recent cases, and we haven't had any unknown source cases. Although, as you say, the situation is very dynamic, and I think the time for underestimating the virus is well past. I would also mention John Ferguson shared a helpful, so obviously on Friday with the Amber Alert decree from New South Wales Health, there were a lot of questions from people in New South Wales Health facilities about how to operationalise that guidance. And so there were some useful frequently asked questions released around that as a guide for New South Wales Health staff, which may also be of interest to this audience. So just a quick plug for Health Pathways, that it remains sort of the source of truth for general practice advice, and certainly if and when any advice comes down from the Department of Health or RACGP in relation to mask wearing in primary care, I'm sure that will go on there. But currently there's links to the current New South Wales Health recommendations on Health Pathways. All right, probably enough on that for now. The next question, what timeframe would we expect to see positive tests from the 155 close contacts of Port Stephens? Now, these contacts certainly had contact over multiple days. So I think it was sort of ranging from about the 19th or 20th of July up until as recently as sort of Monday, Tuesday last week. What we understand of the incubation period is that, you know, generally it's between kind of 3 and 7 days, although there's obviously outliers at either end of that spectrum. But this current week is when we're, you know, really scrutinising things. But to give some comfort, Hunter New England Health does follow up the contacts every day with a text message asking about whether or not contacts are symptomatic. And as Tony alluded to, if any reply yes, then that triggers a process of more intensive follow-up and arrangement of testing for those people. Tony, did you want to add anything?
Or Tony M. Sure. Look, I guess there's been quite a few in that group who've been symptomatic and have negative tests back already. So in terms of rapid transmission, some reassurance there. Flagged that there's a couple more overnight. We'll wait for those results tomorrow with great interest. But then, of course, we'll all be holding our breath just a little to see out the full 2 weeks. But we wouldn't have been surprised to have had more cases by now. So it's gently pleasing to have not had more cases to date.
Thanks, Tony. Okay, so moving on. Mask supply to general practice is being arranged through the PHN. Is there support from the national stockpile for other PPE items such as goggles and gowns, etc.? I think, Catherine, are you able to speak to this?
Hello, yes, I can. This has not changed currently, so we believe that in outbreak situations, if there is no local supply, and I suppose the message we continue to get from the Commonwealth is the stockpile is the supply of last resort. So I believe there are goggles and gowns in the stockpile, but we've had no offers to have them released at this stage. I believe they are being released into residential aged care in Melbourne and other places where they're very acutely needed. I do have a teleconference with the department tomorrow afternoon, so they've increased the communication with the PHNs in Victoria and across the border, and they've included all of the other PHNs in much more frequent discussions around all of these issues, where we're able to give them some advice about what we're hearing on the ground and what's needed. And obviously, if anything changes around any of that, we'll let you know and update Health Pathways and put it in our COVID update on Wednesday morning.
Thanks, Catherine. We'll watch this space. So the next question is from Phil Godden, and this is probably one for you, John Ferguson. Cloth masks okay for GPs to wear?
Oh, well, look, I think the counsel is that we should be, as healthcare staff, be wearing proper surgical masks rather than cloth masks. There is evidence that cloth masks are efficacious, both for source containment and protection, but they're not as good as surgical masks. So I think certainly in the community, cloth masks are great. They can be reused, washed daily, hot washed daily and reused, and I think that's really their forte. We've seen evidence from overseas that general community wearing of masks has been a very effective source control in communities that have community transmission, and I think, you know, that's certainly the way that I think is being encouraged in Melbourne currently because of their extensive community transmission. So not for healthcare staff, I would say.
Thanks, John. And I think that position is outlined in those FAQs. Thanks. Okay, so I think the next question, not quite sure who this one is for, but it's a good question. So from Bronwyn, which is, oh, sorry, there's one that's just bumped up. I'll get to that one. This might be one for you, Tony Merritt. Is the COVID Safe app useful, and is it being used for contact tracing?
Yeah, I think the jury's still out on that. So it is a really important question. As a COVID Safe app user myself, it hasn't been something that we have locally had experience with in a way that's changed our contact tracing. So and so I think the straightest answer there is that the jury is still out there. So really good question.
Thanks, Tony. Okay, the next one, Bronwyn. What is the plan for aged care homes in lockdown to get support from medical providers, RNs, GPs, etc.? Catherine, do you want to kick this one off?
I can, but I'd welcome input from the rest of the panel. So there has been a working group across the whole region who've been working with the key supports at the local health district, ambulance and others around residential aged care. The plan will be different, and we hear this already in Victoria, depending on the facility. So depending on the number of cases in a facility, how equipped and prepared the facility is to manage the patient choice, a whole lot of things. So we've been working with each of the facilities on some scenarios, and certainly their pandemic plans are and preparedness plans are usually very robust and rigorous, and they've got everyone's working through a whole range of things. I guess the short answer is the plan will be dependent and will be managed, and it won't be a decision made by one person or a number of people. We do know that some facilities are able to isolate people in-house and manage them, and we do know that sometimes telehealth supports or mobilising others to come in and assist is going to be possible. But we also know that for some facilities where there's patients in a 4-bedroom ward or it's just not going to be possible to keep people and manage them safely. So I don't know, Bronwyn, if that answers the question, except to say that there have been lots of conversations about it. I am confident that all of the people who are involved in such a decision have already been talking about what they might do, and will hopefully be able to respond appropriately. I think, John, you've been a part of that, but I'd also be keen to hear from Tony and Kim about what their thoughts would be on that one.
Well, I don't know what the plans are, but as a GP, I'd be happy to help out in any way if the situation escalated, whether it was in an aged care facility or the community generally. So, but I'm not privy to that kind of planning.
Thanks.
So I guess we can say from a health district point of view, there's been lots of work done recognising that the local health district might very likely have a key role in support, both in terms of infection control expertise and medical expertise on the ground. So it's very much the thinking at the district level to support as needed. So we can speak to it at that level in terms of well, I don't know, John Ferguson, do you want to add anything further in terms of kind of envisaged support to an established aged care outbreak that might come from, I guess infection control is going to be a very topical issue?
Look, I think it'll be very context specific, and depending on which region, I'm sure the Hunter New England would be putting forward quite a few resources to assist and put all our best feet forward and make sure that we get effective general practice support as well, because continuity is everything as well. I know Caroline Hullock and co have put together quite a sophisticated approach together with population health and others.
Kat, if I could just jump back in and just to provide some whole of region context. So the planning that's been undertaken has included our colleagues on the Central Coast and the local health district there. The response structure is slightly different there. So they've got an aged care response service who are already going into facilities to provide different levels of support from the local health district. And they're also looking at medical workforce surge, might that be required, and they're actually about to advertise for some people who might be prepared to take on a role similar to what Tony's just described to assist where others are unable to continue to provide service or care where that's required. So there's a whole lot of different things, and we're learning all the time we've learned a lot from what happened in Newmarch and the Dorothy Henderson, and less from what's going on in Melbourne so far. I think they're all a bit busy. Yeah.
Thanks, Catherine. Yep. And I think certainly just as another piece of the puzzle, it's been mentioned at a previous webinar that there's an agreement with a private pathology provider to be able to go in and do kind of mass collections of specimens, which is the approach that's currently recommended in terms of when a COVID-19 case is detected in a facility, that there be widespread testing of all staff and residents. So there's lots of moving pieces, but yeah, lots of good planning and collaboration that's happening in the space as well. Okay, we might stick with the aged care theme. There is also another question from Phil Godden about should ACF staff be using masks? John?
Goodness. I don't think any directions come out about that, but I think certainly if we were in a situation where we were experiencing more community spread, that would be highly relevant as source control. We know that various staff do move between facilities, and there's a high casual pool amongst them. I don't believe we're at that state now. Tony Merritt might like to say. I might say the Health Pathways site has got a fantastic resource there around aged care outbreaks and response.
Happy to chip in, John, and just I agree entirely. It's so context specific, and we see that playing out in southwestern sort of greater metro Sydney at the moment. So there are areas there which have the hotspots where the chief health officers recommended all staff in those highly affected LGAs wear masks while at work. But that's not the recommendation locally. It would make sense though if the context changed and we had extensive local transmission. That's certainly a measure I think that's would likely be introduced early. Thanks, Kat.
And Kat, I can tell you that I know a lot of the aged care facilities have interpreted the New South Wales health guidelines as applying to them. And Phil, maybe it's a conversation with the facility just to talk to them, give them some advice, because I do feel sometimes that would be very much appreciated.
Great, thanks everyone. Good. Oh yes.
In the Amber Alert frequently asked questions published by New South Wales Health, there is a little section in there about aged care facilities and mask wearing.
Surgical masks.
Yeah, and it does recommend it for healthcare workers in aged care facilities.
Yep. Great. Thanks. And while you've got the mic, Kim and Tony, I might throw this one to you, which is a question about how can counselling be conducted whilst wearing a mask? Interested in your experience.
Yeah, so it's a bit of a paradox, because you're trying to protect the elderly, and often they're the ones that use facial cues and watch your lip reading to be able to communicate with you and to understand us. So that can be challenging, and I found myself shouting a lot more. And I guess I'm just hoping that the words that I'm saying for other people, the words that I'm saying, and my other facial expressions are helping to that kind of non-verbal communication that normally happens in a face-to-face consultation pre-COVID. But it is challenging, and I think the biggest thing that I'm aware of is with the elderly or the very elderly who are hard of hearing. Do you have any comments about that?
No, I guess it's just a fine line to tread. There's a balance that we have to find between protecting our patients, but also providing, the service that they want for, especially for counselling.
Thanks for those insights, Kim and Tony. Okay, well, there's a couple of questions that relate to GPs assisting with clusters and how this can happen, and that might actually be a good subject for a future webinar, potentially pulling in someone that's had experience helping in a cluster setting. But certainly, you know, our experience has been really that it's been mostly around facilitating testing for people that live in that area, and helping to also correct some of, I guess, the misinformation that goes around when there is a cluster, and just serving that education and advocacy role that you all do so well. But potentially we take that question to as the subject of a future webinar in terms of GP assistance in cluster responses. Just being mindful of time, I might throw a couple of questions your way, Tony Merritt. There's a few questions about exposure. So one of them is about time restriction on exposure to patients. Health pathway states less than 15 minutes. And there's also a question about why are media currently saying testing if you stayed at Thai Rock Cafe for 2 hours, not 20 minutes?
Put myself on mute, sorry, after all this time. So I think these go to the heart of the definition for close contacts that we use regularly. And there are two elements to that. There's time and proximity. And so anybody who's in that close face-to-face within 1.5 metres for more than 15 minutes cumulatively over a week is a close contact. And so that plays into that discussion around GP consultation times, when you'd often be, ideally you'd space yourself beyond the 1.5 metres, except for the time when that's obviously not possible. But that plays into considering keeping consultations short. I think the question here asks whether that is whether there's a restriction on longer consultations out of my expertise there, but I would presume there's no restriction. It's just an advice about the benefits of keeping them shorter where that's kind of feasible. So close contacts, that proximate contact cumulatively 15 minutes over a week, or same airspace, so a room for a period of more than 2 hours. And that plays into the second question. So we're interested in people who are in the same airspace, a room like a restaurant, for more than 2 hours. And so the specific question was the latest release about the Hard Rock that's up in Sydney. Talks about patrons who are there for more than the 2 hour time, and that's playing into that other definition. So they're the things, if we're talking to people, if we're talking to you about determining whether you've been in close contact, we'll be interested in proximity and duration with those two elements playing together. Thanks, Kat.
Thanks, Tony. Maybe just another one for you, which is, if I get symptoms and get tested, do any of my close contacts need to isolate until my test result is known?
Yeah, almost certainly not. We can always add an asterisk and a caveat, but these people are contacts of contacts, and so for the what's critical, just to reinforce Kat's message from earlier, anybody who's being tested for COVID needs to isolate themselves effectively until the result comes back, and then there'll be a small group who need to keep isolating because they fell into one of those other categories. They're close contacts, or they've been to one of those venues that triggers the mandatory 14-day isolation. So for most people, they're going to be the ones who isolate till the test result comes back and symptoms resolve. Their immediate close contacts almost always don't need to, but it does kind of swing on how well they're isolating, right? So the whole point of isolating, waiting for your result, is that you really are not putting other people at risk in the meantime. So some energy needs to go into that in terms of keeping separate from other people in the house and not putting them in at risk of being infected. And I guess every now and then there's a really high risk situation where we'd take a precautionary approach there, you know. But for as a general rule, contacts of people who are awaiting tests, as long as that kind of isolation is being maintained, we wouldn't restrict their movements. That's the takeaway.
Thanks very much, Tony. Okay, I'm mindful we're running short of time, but I might throw this last one to you, John, which is a question about what is the current role of serology and saliva testing?
Oh, right, okay. Well, certainly serology is seen as an adjunct to public health investigation of outbreaks and surveillance in general. We don't regard it as a reliable test for acute infection by any means. There's a significant delay in time until someone becomes seropositive, but it's been used very effectively to link outbreaks and as part of a surveillance thing. I guess the other role for serology is looking at immune determinants and whether people have neutralizing antibody on board. So, a majority of patients actually do develop high levels of neutralizing antibody, and there is slow waning over time, but that's expected with any viral infection. What we don't know is how much is enough, and we don't know the interaction between that and T-cell immunity. So there is some evidence that just normal coronavirus infection, seasonal coronavirus, leads to some T-cell levels of immunity in a proportion of the population against COVID-19. So all of those pieces of the puzzle haven't been put together yet. I guess most of us are optimistic about vaccine developments. There are some very good candidate vaccines that are already in phase 3 trial and have shown to be immunogenic. So it's very early days, but there's reasonable optimism around that. So serology testing, in general, it's in the public health terrain for use there.
Thank you very much, John. Oh, yes, I'm back. Sorry, hit the wrong button. Yeah, no, that is a very optimistic note to finish on. And I would add the comment that there is a little sort of commentary on uses for serology within the health pathways. So feel free to have an explore there. And we have sadly run out of time. It's been a really fantastic panel discussion. I might hand back to Catherine if you wanted to close off.
Thanks, Kat. And look, thanks to all the panelists and all the people asking the questions for their time. It's kind of nice to be doing it at home tonight in our slippers, but hopefully this has been useful for everybody. I got one final plug, which is when the PCIOs are out and about delivering masks, they're going to be asking for to update all the emergency contacts from the general practices. We are looking at a process where we might be able to send localized mass SMS text for when things change that might help, because we know that if a new clinic's opening up or something else is happening, we'd really like to be able to let you know as quickly as we can. So if you do get asked that question, that would be really great. As always, a plug for the Slido evaluation. Please just take a couple of minutes, let us know, are we on the right track? What else do you want to know about? And we'll continue to do this as frequently as needed and as frequently as people are finding it helpful. So with that, I'll wave to all the panel and say thanks very much, and hope everybody stays safe and does all the things. Oh, hang on, what's that? But is Denise online?
Yeah.
Oh, hi Denise and bye Denise. Well, there's my shout out for tonight. Hi Denise Lyons. All right. So thanks everybody, and we'll
Thanks,
you.
guys.
See ya.
Thanks so much. Take care, everyone.
Bye.
Bye.